Welcome to the Epidemiology and Prevention of Vaccine Preventable Diseases webinar series. I'm Candace Robinson, a medical officer in the Immunization Services Division of the National Center for Immunization and Respiratory Diseases, or NCIRD, at the CDC, and I'll be your moderator for today's session. To participate in today's program, all you will need is an internet connection. Here are our learning objectives. At the conclusion of this session, the participant will be able to describe the different forms of immunity, describe the different types of vaccines for each vaccine preventable disease, identify those for whom routine immunization is recommended. For each vaccine preventable disease, describe characteristics of the vaccine used to prevent the disease, describe an emerging immunization issue, locate resources relevant to current immunization practice, and implement disease detection and prevention healthcare services to prevent health problems and maintain health. Today is September 7th, 2016, and on the agenda is the Epidemiology and Prevention of Vaccine Preventable Diseases Pink Book, specifically the topic Influenza, which draws from the chapter on influenza. This will be presented by Dr. Raymond Strickis, a medical officer in the Communication and Education branch. Continuing education, or CE credit, is available only through the CDC ATSDR training and continuing education online system at www.2a.cdc.gov/TCE online. If you are watching this version live, CE credit for the session will expire on October 11th, 2016. If you're watching the Enduring Archive version, CE credit for the session expires on June 1st, 2018. When obtaining CE, you will be required to provide a verification code. Watch and listen for the verification code during the course. Verification codes will not be given outside of this presentation. CDC, our planners, and our presenters wish to disclose they have no financial interests or other relationships with the manufacturers of commercial products, suppliers of commercial services, or commercial supporters. Presentations will not include any discussion of the unlabeled use of a product or a product under investigational use. CDC does not accept any commercial support. A list of resources for influenza will be available, and the web page is www.cdc.gov/vaccines/pinkbook/pb14.asp. If you have a question during this presentation and related to this presentation, please type your question in the QA pod. I will collect these questions during the presentation, and then we will address them during the question and answer period, which will follow Dr. Strickis' presentation. I will now turn the session over to Dr. Strickis.
Thank you very much, Dr. Robinson. So let's delve into the multifaceted topics of influenza viruses, disease, and vaccines. Influenza is a highly infectious viral illness. The name influenza originated in 15th century Italy from an epidemic attributed to the influence of the stars, hence the name. The first pandemic or worldwide epidemic that clearly fits the description of influenza occurred in 1580. There have been at least 4 pandemics of influenza in the 19th century and 3 in the 20th century. The pandemic of Spanish influenza, perhaps the most notorious in 1918-1919, caused at least an estimated 21 million deaths worldwide and likely more. The pandemics in 1957 and 1968 were of lesser severity. The first pandemic of the 21st century occurred in 2009 with the H1N1 virus, about which we'll talk more later. The first influenza virus was isolated in a laboratory in 1933. The virus is a single-stranded, helically shaped RNA virus of the orthomyxovirus family. The nuclear material determines the three basic antigen types, A, B, and C. Type A influenza has subtypes that are determined by the surface antigens or proteins, hemagglutinin and neuraminidase, or the H and the N that you commonly hear and will use henceforth to talk about type A viruses. Three types of hemagglutinin in humans, H1, H2, and H3, have a role in virus attachment to cells. Two types of neuraminidase, N1 and N2, have a role in virus penetration into cells of humans. There are some differences in the three types. Type A influenza can cause moderate to severe illness and affects all age groups among humans and other animals. Type B influenza causes milder epidemics, changes less rapidly than type A, and affects only humans and primarily children. Type C influenza is rarely reported in humans, and it does not cause epidemics or pandemics. Here you can see an illustration of a type A influenza virus, and this illustration is also on the cover of the 2015 Pink Book. The influenza viruses are named in order by the virus type, A or B, their geographic origin, the strain number in the laboratory identifying the virus, the year the virus was isolated, and for type A virus, the subtype is defined by the hemagglutinin and neuraminidase. So the virus above is type A, California, number 7 in the lab from which it was isolated. The virus was isolated in 2009, and it is of the H1N1 subtype. Antigenic drift and shift can affect the influenzaviruses that we see and cause disease. Antigenic drift is responsible for minor changes in the surface proteins caused by point mutations in the genes that originate those proteins and may result in an epidemic or serious disease. This type of mutation occurs in both influenza A and B viruses. However, antigenic shift can cause a major change and a new subtype, significant changes in the hemagglutinin and neuraminidase. This is caused by an exchange of gene segments between viruses and may result in a pandemic. Antigenic shift only occurs in influenza A viruses. Only 7 years ago, in 2009, the H1N1 pandemic was declared by the World Health Organization, or WHO. And this pandemic was caused by an antigenic shift in the virus antigens of this H1N1 virus. In April 2009, the novel type A H1N1 virus appeared and quickly spread across North America. By May 2009, the virus had spread to many areas of the world. So this was the first influenza pandemic since 1968. Pandemic monovalent influenza vaccine was rapidly produced in the United States and deployed in a nationwide vaccination campaign that many of you listening may have participated in. This pandemic's impact, while relatively modest compared to the 1918 and 1957 pandemics, was still significant. 61 million people in the United States were estimated to become ill, or about 20% of the population. Over 270,000 hospitalizations occurred, 80% of which were in persons less than 65 years of age, and over 12,000 people are estimated to have died from the pandemic virus. These data are summarized in more detail on the CDC Influenza Pandemic A H1N1 website. Transmission of influenza viruses is respiratory. Replication occurs in the respiratory epithelium with subsequent destruction of the cells, but viremia, or circulation of the virus in the bloodstream, has been rarely documented. Influenza viruses are shed in respiratory secretions, usually droplets, most contagious within 6 feet of an infected person for 5 to 10 days after infection. Clinical features of influenza illness include that the incubation period of influenza is usually 2 days, though it may range from 1 to 4 days. Now, 50% of infected persons will develop what are called classic symptoms of influenza disease, and this is characterized by the abrupt onset of fever, myalgia, sore throat, non-productive cough, and headache. The fever is usually 101 to 102 degrees Fahrenheit, and accompanied by extreme fatigue or prostration. The onset of fever is often so abrupt that the exact hour is recalled by the patient. Myalgias mainly affect the back muscles. Cough is believed to be a result of tracheal epithelial destruction. Additional symptoms may include rhinorrhea or runny nose, headache, substernal chest burning, and ocular symptoms such as eye pain and sensitivity to light. The illness lasts usually between 3 and 7 days without complications. The severity of the illness depends on prior experience with related variants of the infecting virus. Complications of influenza illness include most frequently pneumonia and most commonly secondary bacterial pneumonia, usually from either Streptococcus pneumoniae, Haemophilus influenzae of any type, or Staphylococcus aureus. Primary influenza viral pneumonia is an uncommon complication but has a high fatality rate. Rye syndrome is a complication that occurs almost exclusively in children taking aspirin, primarily in association with influenza B or varicella zoster or chickenpox infection, and presents with severe vomiting and confusion, which may progress to coma due to swelling of the brain or encephalopathy. Other complications may include myocarditis or inflammation of the heart muscle, and worsening of chronic bronchitis and other chronic pulmonary diseases. Death is reported in less than 1 per 1,000 cases, and the majority of deaths typically occur among persons 65 years of age and older. The number of influenza-associated deaths varies substantially by year, virus type, subtype, and age group affected. In recent years, there has been an average of 23,607 deaths due to influenza each year, but with a wide range from 3,349 in 1985 to 48,614 deaths in 2003. Persons 65 years and older typically will account for 90% of the deaths. Deaths are 2.7 times more common when type A H3N2 influenza viruses were prominent. The highest rates of complications and hospitalization occur among persons 65 years and older, as I said, but also young children, and among persons with certain underlying medical conditions, that is, chronic diseases such as heart or lung disease. On average, more than 200,000 hospitalizations are attributed to influenza each year. 37% of the hospitalizations, though, are among persons younger than 65 years of age. And again, a greater number of hospitalizations, as with deaths, occur in years when type A H3N2 influenza viruses circulate. School-age children typically have the highest attack rates during community outbreaks, and they serve as a major source of transmission of influenza within communities. There are numerous reports of influenza outbreaks beginning in schools and spreading to the school's communities, and then these outbreaks slow or stop when school closed for the winter holidays and the children disperse. The reservoirs for influenza disease and viruses are humans and animals, only for type A, and these can include various mammals such as horses and dogs and many species of birds. Transmission again is respiratory through airborne droplets. And there's a temporal pattern with a peak from December to March in temperate climates such as the United States. However, this pattern may shift earlier or later. Now, peak months for influenza activity in the United States since 1982 have been, in descending order, February, December, March, and January, but we often can see influenza activity begin as early as October and extend into May and sometimes beyond. The disease is communicable, or people are infectious 1 day before symptoms begin to 5 days after the onset of symptoms in adults. Influenza virus infection cannot be diagnosed accurately based on signs and symptoms alone. Laboratory testing is necessary to confirm the diagnosis. Virus isolation is essential for virologic surveillance. And appropriate clinical specimens used for virus isolation include nasal washes, nasopharyngeal aspirates, nasal and throat swabs, tracheal aspirates, and bronchoalveolar lavage. One disadvantage of virus isolation is that it requires several days, so it is not very useful for clinical decision making. Paired serum specimens are required for serologic diagnosis of influenza virus infection and are generally a research tool. IgG or immune globulin G serologic testing is generally not useful for clinical diagnosis. One also needs to know the patient's vaccination history. The acute phase serologic specimen should be collected within 1 week of the onset of illness and preferably within 2 to 3 days. The convalescent phase sample, so you need 2 samples for serologic diagnosis, should be collected approximately 2 to 3 weeks later. A positive result is a 4-fold or greater rise in titer between the acute and convalescent phase samples to one type or subtype of virus. This table is adapted from the CDC Influenza Diagnostics website listed at the bottom of the slide, and it lists most commonly used diagnostic tests for influenza, beginning with what I already mentioned, traditional viral culture in cell culture. There are a number of other tests listed as well, which can give results more quickly than does viral culture, underlined at the top of the slide. I will only discuss 2 of the other kinds of tests now, which are also underlined and in yellow text. The first of those 2 is real-time polymerase chain reaction, or RT-PCR, and it is the most sensitive method for the detection of influenza virus and is the gold standard for influenza diagnosis. The use of these molecular techniques to directly detect virus in respiratory samples can provide rapid identification of viruses, that is, within hours, if not faster. The second important category at the bottom of the slide are commercially available rapid diagnostic kits, which test for the presence of viral antigens or proteins. And although these tests are usually less sensitive than RT-PCR testing, they are highly specific. Currently available rapid influenza diagnostic tests fall into 2 groups that test which detect both influenza type A and B viruses but don't differentiate between the virus types, and those that detect both A and B viruses but can distinguish between the 2. Results from these rapid influenza antigen detection tests can be available in 15 minutes or less. Now, these rapid diagnostic tests for influenza can help in the diagnosis and management of patients who present with signs and symptoms compatible with influenza. They also are useful for helping determine whether outbreaks of respiratory disease, such as in nursing homes and other settings, might be due to influenza. There are many brands of these tests which detect influenza antigens or proteins. They're widely used in clinical settings, and these are discussed in more detail on the CDC Influenza website. Now, as I said, rapid influenza diagnostic tests are not terribly sensitive. About 50 to 70% of influenza infections will be picked up by them. They are highly specific. That is, false positives are unlikely. So if the test is positive, you can pretty well believe it. If it's negative, you may want to still treat the person as if they have influenza because false negatives do occur, particularly when compared with viral culture or RT-PCR. This graph from CDC's influenza surveillance team demonstrates the seasonality of influenza, in this case using pneumonia and influenza mortality as a marker for annual influenza outbreaks. These peaks in mortality follow very closely, usually within a week or 2 of influenza virus isolations and influenza-reported illnesses. Here are some influenza vaccine myths which I expect you have heard before and which I'll discuss briefly as we can go through the presentation. And these include statements such as, gee, every time I get the vaccine, I get sick. Flu vaccine can give you the flu. If I get the vaccine in October, it won't work in February or March of the next year. It's not safe. Flu vaccine doesn't work. Why get the vaccine every year? Isn't last year's vaccine good enough? So let's talk about the influenza vaccines available in the United States. The inactivated or IIV and the live attenuated vaccine or LAIV are the 2 types. Inactivated vaccine can be administered either intramuscularly or intradermally. LAIV is only given intranasally. Now, an important message is that for the coming influenza season, LAIV is not recommended for use by the ACIP and CDC in light of low effectiveness or effectiveness that couldn't be detected against the pandemic H1N1 2009 influenza virus in testing done during the 2013-14 and 2015-16 seasons. Therefore, the Advisory Committee on Immunization Practices, or ACIP, has made the interim recommendation that LAIV, the quadrivalent vaccine, should not be used in the U.S. this season. Because LAIV is still a licensed vaccine that might be available and that some providers might elect to use for informational purposes, I'll refer to previous recommendations for its use. I'll describe its prior effectiveness and adverse event profiles as well. LAIV viruses do replicate in the nasopharyngeal mucosa of the vaccine recipient. Again, they're given intranasally. Vaccinated children can shed vaccine viruses in nasopharyngeal secretions for up to 3 weeks. There has been only one documented report of transmission of vaccine virus from a vaccinated person to a contact who was a child in a daycare setting, and the contact who received or developed the virus from the other child also developed a mild respiratory illness from which the child completely recovered. The reference for that study is listed on the slide. Inactivated vaccine is considered about 60% effective amongst healthy persons younger than 65 years of age. In 2015-16, the season just concluded, IIV was about 49% effective in all age groups studied, or near the usual expected effectiveness. The vaccine has been 50 to 60% effective in preventing hospitalization among elderly persons, and also as much as 80% effective in preventing death among elderly persons. These estimates simplify a great many studies and assume a good match between wild influenza viruses and those represented in the vaccine. For a very detailed discussion about influenza vaccine effectiveness in these populations and others, including children, pregnant women, persons with chronic medical conditions, and compromised immune systems, please review the recently published ACIP recommendations on use of influenza vaccine for 2016-17, which are referenced at the bottom of the slide. So influenza vaccine, IIV in this case, is usually modestly effective preventing influenza illness and complications, but it works best if there is a good match between wild and vaccine viruses. In 2014-15, for example, we did not have a good match and a lot of illness despite many vaccinated people. Here's a further example of IIV effectiveness in an older study from a nursing home in Michigan from 1982-83. Vaccinated residents, represented by the black bars here, had fewer illnesses by a third to a half and fewer complications, specifically hospitalizations, pneumonia, and deaths, when compared with unvaccinated residents, and their incidence is shown in the gray bars on these graphs. We'll talk briefly about LAIV efficacy for your reference. It's been reported that LAIV is 87% effective against culture-confirmed influenza in healthy children 60 to 84 months of age in older studies. There was a 27% reduction in some studies in febrile otitis media, or OM. A 28% reduction in OM with accompanying antibiotic use was noted as well. And decreased fever in OM in vaccine recipients who developed influenza was also noted. Again, all of these in older studies. Recent studies from the last 3 years did not demonstrate LAIV effectiveness in preventing influenza-related illnesses, and again, ACIP recommended for 2016-17 this vaccine not be used. The current inactivated or IIV recommendations are that all persons 6 months of age or older receive influenza vaccine, and that protection of persons at higher risk for influenza-related complications should continue to be a focus of vaccination efforts as providers and programs transition to routine vaccination of all persons aged 6 months or older. We've only been recommending persons 6 months or older, all persons 6 months or older receive influenza vaccine for about the last 6 years, so to some of us it may still be a new phenomenon. Now, if vaccine supply were limited, which we hope it will not be, vaccination efforts should focus on delivering vaccination to the following groups of persons at increased risk of complications. Children 6 months through 4 years, that is up to 59 months of age. Persons 50 years and older. Persons with chronic pulmonary, including asthma. Cardiovascular, not including hypertension. Renal, hepatic, neurologic, hematologic, or metabolic disorders, the latter including diabetes mellitus. Persons who are immunosuppressed, including immunosuppression caused by medications or by human immunodeficiency virus, or HIV, and women who are or will be pregnant during the influenza season. Additional groups who should receive IIV include children 6 months through 18 years of age who are receiving long-term aspirin therapy for other conditions such as juvenile rheumatoid arthritis or Kawasaki disease, and who therefore might be at risk for experiencing Reye syndrome after influenza virus infection, residents of nursing homes and other chronic care facilities, American Indians and Alaskan Natives, persons who are extremely obese with a body mass index of 40 or greater, healthcare personnel who, if infected, can transmit infection to their vulnerable patients, household contacts and caregivers of children younger than 5 years of age, and adults 50 years of age or older, with particular emphasis on vaccinating contacts of children aged younger than 6 months, because those children younger than 6 months cannot receive influenza vaccine or antiviral drugs. Lastly, household contacts and caregivers of persons with medical conditions that put them at higher risk for severe complications from influenza should also be a priority for vaccination. Now, so why should pregnant women receive influenza vaccine? That is because their risk of hospitalization due to influenza is 4 times higher than non-pregnant women who have similar underlying health status and age. The risk of complications of influenza in pregnant women are comparable to non-pregnant women with high-risk medical conditions, so therefore vaccination with IIV is recommended if a woman is pregnant during the influenza season, and also you should know that vaccination of that pregnant woman can decrease the risk of influenza illness in newborn infants for about their first 6 months of life by 50% or more. So you get a twofer. You get the pregnant woman protected, and you protect her unborn infant for that infant's first 6 months of life outside the womb. Lastly, influenza vaccination can occur or be given during any trimester of pregnancy. Persons with HIV infection are also at increased risk for complications from influenza. IIV induces protective antibody titers in many HIV-infected persons, and IIV should be given and will benefit many HIV-infected persons. There are 3 contraindications and precautions for IIV. A firm contraindication is a severe allergic reaction, specifically anaphylaxis, to a vaccine component or following a prior dose of inactivated influenza vaccine. Moderate or severe illness is a precaution for vaccination, and ideally you would wait until that illness is abated before vaccinating to avoid confusing any possible adverse event or reaction from the vaccine with an exacerbation of the illness. And a history of Guillain-Barré syndrome or GBS within 6 weeks following a previous dose of any influenza vaccine is a precaution, and one has to weigh the risks or benefits of vaccination versus the possibility of recurrent GBS. There are precautions for administration of LAIV, although again this vaccine is not recommended for use during the 2016-17 season. These include persons with chronic medical conditions, children 5 years or older with asthma, moderate or severe acute illness, and history of Guillain-Barré syndrome or GBS within 6 weeks following a prior dose of any influenza vaccine. For IIV, common adverse events include pain, erythema, and swelling, that is local reactions, and Guillain-Barré syndrome, which is uncommon but is expected to be of greater incidence among persons who have a prior history of Guillain-Barré or GBS than among persons with no history. For LAIV, nonspecific systemic symptoms are common. Offer some more detailed and quantify adverse reactions. For IIV, we can estimate about 15% to 20% of vaccine recipients will report local reactions such as soreness or redness at the vaccination site. Less than 1% of IIV recipients will report fever, malaise, or myalgia, and these symptoms often make people think, oh, I got the flu from the flu vaccine, but no, it's a reaction of your body's immune system to the vaccine, having you make antibody and be protected, and these symptoms generally dissipate within 24 hours. You cannot get the flu from the flu shot. Allergic reactions such as hives, angioedema, or anaphylaxis are rare. Anaphylaxis, for example, the incidence is estimated to be somewhere between 0.45 to about 2 per million vaccinated persons. So it is very unlikely you'll ever see that reaction, though it is always a possibility you should be prepared for. Adverse reactions after LAIV among children. There's been no significant increase in upper respiratory or URI symptoms fever, or other systemic symptoms in children compared to placebos who've gotten intranasal sprays. There is an increased risk of wheezing in children 6 to 23 months of age after receipt of LAIV. And among adults, there may be a significantly increased rate of cough, runny nose, nasal congestion, sore throat, and chills reported among vaccine recipients. However, there has not been an increase in the occurrence of fever in LAIV recipients who are adults. And there have to date been no serious adverse reactions firmly identified for children or adults after administration of LAIV. Now, a word about antiviral drugs. Some providers may consider prescribing antiviral agents, especially for high-risk persons, that is, high risk for complications of influenza, within 48 hours of symptom onset if influenza is suspected or confirmed by laboratory testing. However, two older drugs, amantadine and rimantadine, many of you may have used in the past, are not recommended for use because there is documented high-level resistance in U.S. influenza isolates. So the only two drugs you should consider using are zanamivir or oseltamivir, and these are neuraminidase inhibitors. They are considered effective against both influenza A and B, and oseltamivir and zanamivir may be used as prophylaxis for persons who, for whatever reason, cannot receive influenza vaccine. Please see the influenza website listed on the slide for more details about use of these drugs. CDC and its state and international partners conduct influenza surveillance for several reasons: to monitor prevalence of circulating viral strains and detect new strains, which helps in strain selection for new influenza vaccines the following year; to estimate influenza-related morbidity, mortality, and economic loss; to rapidly detect outbreaks; and assist disease control through rapid preventive action once an outbreak is detected. For the 2016-17 season, this slide lists the antigens or the virus proteins contained in the trivalent and quadrivalent vaccines for this year. There will be a new H3N2-like antigen included, which should be helpful in preventing serious disease. The two B strains are the same ones we had last year, but they've traded places. So the B Brisbane will be represented in all vaccines this season, both trivalent and quadrivalent, and the B Phuket type viruses are represented only in the quadrivalent vaccines. So the trivalent vaccine has 3 viral antigens, 2 A antigens and 1 B antigen, while the quadrivalent vaccine has the additional B antigen, in this case the B Phuket antigen. The changes in the viruses included in this year's influenza vaccines remind me of another reason why it's recommended people receive influenza vaccine every year. Besides the fact that immunity will usually wane in most persons within a year after vaccination with IIV and LAIV, the viruses usually change in the vaccine from one year to the next, reflecting the predicted viruses for the forthcoming year. So last year's vaccine is usually not good enough to protect you from the viruses expected in the current year. There is one new inactivated influenza vaccine available this year and one with expanded indications. An MF59 was an adjuvant or a chemical used to improve the immune response trivalent inactivated influenza vaccine, abbreviated AIIV3 because it's trivalent, called Fluad, made by the company called Securus from North Carolina, was licensed by FDA in November 2015, but only for persons 65 and older. And this vaccine in trials in Europe was found to be superior to vaccine that did not have this adjuvant, but this vaccine has not been compared to other adjuvanted vaccines or to the high-dose vaccine we've had in the U.S. for the older population for several years. We believe it is an acceptable alternative to other vaccines licensed for persons in this age group. The other vaccine is Flucelvax, which has been available for several years, a cell culture-based inactivated influenza vaccine, abbreviated CCIIV4, also from the company called Securus, licensed by FDA in May 2016, and they dropped the age indication down to persons 4 years and older. Previously it was only for persons 18 years and older, and CCIIV4 is an acceptable alternative to other vaccines, again licensed for persons age 4 and older. ACIP and CDC don't feel we have enough data to express a preference for any particular vaccine product for any of these age groups. So just to iterate, the current ACIP recommendations we've had in existence 2010 Annual influenza vaccination is recommended for every person in the United States 6 months of age and older. More specifically, providers should make a special effort to vaccinate persons at increased risk of complications of influenza, summarizing information I've given to you earlier: children 6 months through 4 years, persons 50 years and older, persons with underlying medical conditions, pregnant women, close contacts and caregivers of high-risk persons, and healthcare personnel who also really fall in the category of caregivers to high-risk persons. The IIV dosing schedule does vary by age. Children 6 through 35 months of age should receive a special pediatric formulation of IIV with 0.25 milliliters of vaccine either once or twice this season, depending on prior vaccination status, which I'll discuss shortly. Children 3 through 8 years should receive a larger dose, 0.5 milliliters either once or twice, depending on prior vaccination. And children and adults 9 years and older should receive one dose of 0.5 milliliters each year. Here is the flowchart or algorithm from the 2016-17 ACIP recommendations for influenza vaccination to help you determine which children less than 9 years of age should receive 2 doses of influenza vaccine this year. It is essentially unchanged from last year in that if a child has received 2 doses of any influenza vaccine before July 1 of this year, and that includes LAIV as well as IIV, she or he need receive only 1 dose of inactivated influenza vaccine this year. If you and the child's family are uncertain of how many doses she or he has received in the past, or the child has only received 1 dose ever in the past, then 2 doses are indicated this year. The 2 doses should be given at least 4 weeks apart. The ACIP and CDC recommendations regarding influenza vaccination of persons with known severe egg allergies have been changed, primarily because there is now good evidence that such persons can safely receive inactivated influenza vaccine. So, looking at the slide, persons with history of egg allergy who have experienced only hives after exposure to egg should receive influenza vaccine, and any licensed and recommended vaccine, any age-appropriate vaccine, IIV or the recombinant vaccine, Flublok, are appropriate for the recipient's age and health status may be used. Now, persons who report prior reactions to egg involving symptoms other than hives, such as angioedema, respiratory distress, lightheadedness, or even anaphylaxis, requiring emergency medical intervention, may also receive any licensed and recommended vaccine appropriate for their age group and health status. The vaccine should be administered in an inpatient or outpatient medical setting that is appropriate and has healthcare providers who can recognize and manage severe allergic conditions. Lastly, a previous severe allergic reaction, that is anaphylaxis to influenza vaccine or one of its components, regardless of which component is suspected of being responsible for the reaction, is a contraindication to future receipt of the vaccine. Timing of vaccination is a common question we receive. You should know that vaccination, that is influenza vaccination, should occur before the onset of influenza activity, and healthcare providers should offer vaccination by the end of October if possible. Children aged 6 months through 8 years who require 2 doses should receive their first dose as soon as possible after vaccine becomes available, and the second dose 4 or more weeks later. Vaccination should continue to be offered as long as influenza viruses are circulating and unexpired vaccine is available, and that may in some years go into May or even June. To avoid missed opportunities for vaccination, providers should offer vaccination during routine healthcare visits and hospitalizations when vaccine is available. Now, the question commonly comes up of how long protection lasts after vaccination. One of those myths that the vaccine doesn't protect for very long. And evidence from some clinical trials indicates that protection against viruses that are antigenically similar to those contained in the vaccine extends for at least 6 to 8 months, particularly in non-elderly populations. However, some studies have noted a decrease in vaccine effectiveness, particularly against influenza A, H3N2 viruses, and again, most markedly in older adults. However, this effect has not been consistently observed across age groups and seasons and might be partially attributed to factors such as circulation of antigenically variant influenza viruses that are not well matched to the vaccine given to the subjects studied and during the influenza season studies. So at this time, we still recommend 1 dose of influenza vaccine per season for older children, that is 9 years of age and older, and adults. Here's a screenshot of the CDC website on influenza and the URL address. As you can see, there are several topics you can click on to find much more detail. The flu vaccine finder in the upper right may be helpful for some of your patients to locate vaccine by their zip code area. There is also a table that lists all the influenza vaccines available for this season, and if you click on the health professionals section, you would find it there. Here are some resources that may be helpful for you in looking up influenza recommendations and other information. The ACIP's Influenza Recommendations webpage, the CDC's Influenza webpage, the Immunization Action Coalition webpage, and the Children's Hospital Philadelphia Vaccine Education Center webpage as well. There is also a list of selected references at the end of the influenza chapter in the pink book itself. In closing, here's an old recommendation how to avoid influenza. This is from the 1918 pandemic, and these children are gargling because they were told to gargle daily to avoid influenza. I'll add to that and say the best recommendation to avoid influenza is to get an influenza vaccination this year and every year. Thank you very much. Dr. Robinson, back to you.
Thank you very much, Dr. Strickus. On your screen, you will see continuing education credit information, including the verification code for today's course. Please make note of this verification code as it will not be given outside of this presentation. Today's verification code is FLU-824, and this verification code applies to both the live and the enduring program. I'll repeat the verification code, FLU-824. There is also a resource pod on your screen where you can click on to obtain instructions for CE credit. Now I will review some of the questions we received during our program. I will remind listeners to make sure that your question is related to today's content. So, first question. If a dose of LAIV is administered this season, will it count as a valid dose?
Yes, CDC has discussed this issue with its influenza staff, and because the recommendation about not using LAIV because of our concern about its effectiveness has been widely disseminated, we assume that if a practitioner uses that vaccine, he or she has advised the client or the patient about the risks and benefits of that vaccine and has done so for some good reason. And the data about LAIV lack of effectiveness are mixed. CDC believes they were significant enough, and ACIP agreed to not recommend the vaccine, but we do not believe that people who receive LAIV need to receive a subsequent dose of IIV or an activated vaccine to assure immunity. So the LAIV dose can count either as 1 dose for an older child or adult or as part of the priming series for a child.
Great, thank you so much. Our next question is August too early to start vaccination?
August is not too early to start vaccination. When I talked about timing of vaccination, I said once you start vaccinating as soon as vaccine is available. This is particularly relevant to children who need 2 doses. There are certainly the concerns I expressed about older adults and people who are frail or infirm, and some have taken on themselves to vaccinate in October or even November, closer to the time influenza appears in the United States, because they say, well, if it only protects for as minimum a period of 6 months, if I give it in October, I'll protect people out to April, and that ought to catch most of the season. I think that's a decision the practitioner can make depending on the population they're treating. Certainly, though, if you're treating children, working age population, there's no reason to not vaccinate in August or September when the vaccine's available. If you're dealing with a long-term care population, one can consider vaccinating a little later in the year, but you want to get that vaccine done, as I said earlier, by the end of October, because we have seen outbreaks in long-term care facilities in early November in the past.
Thank you very much. Our next question is, what does CDC predict for the influenza vaccine match or effectiveness for this coming season?
CDC predicts that if you've seen one influenza season, you've seen one influenza season, and we don't have a prediction. There are no data at this point either way, no data suggesting there's a reason to fear or worry about a poor match, but there are very few influenza virus isolates from the U.S. that have been studied so far. There's no reason to think we're going to have a bad match, but we have had surprises in the past, as recently as 2014-15. At this time, we have no reason to think the match will be poor or untoward, but stay tuned and follow our surveillance data, which will begin in earnest beginning the first week in October when surveillance revs up again, and we'll see how it goes. Right now, there is no hint or suggestion that there'll be a poor match or any diminution of the effect of influenza vaccine for 2016-17.
Great, thank you. Our next question, invalidation of an influenza vaccine. Should we observe age limits? For example, if a pediatric formulation is given to an adult, should the dose be repeated?
In that specific circumstance, a pediatric formulation, a 0.25 milliliter dose, is given to an adult. That's not sufficient vaccine dose to assure immunity in persons 9 years of age or older. So if you discover that error on the same day and the person's still in your clinic setting, you could give them another 0.25 dose in the other arm or another limb, and they're done. If they're gone and they can't come back for another day, you'll have to give them a 0.5 milliliter dose to assure protection.
Thanks. Our next question, is IIV okay for a breastfeeding mother?
There is no reason to not give IIV to a breastfeeding mother. One would engender antibodies in the woman. You'd offer her protection. There is no evidence of ill effects on the child who's breastfeeding, so it's perfectly fine to give that to a breastfeeding mother.
Great, thank you so much. And the next question is, what is the minimum interval between LAIV and other live vaccines? If we see a child who happened to have gotten an LAIV vaccine during this season, can you remind us what the minimum interval is between that and any other live vaccine they may
Yeah, out of an abundance of caution, and this was discussed earlier in the series in the general recommendations on immunization talks, we recommend separating all live vaccines, including LAIV, varicella, MMR, and yellow fever by at least 4 weeks if they're not given on the same day. And this is because of the theoretical concern of possible interference of one vaccine on one given less than 4 weeks later in its replication and then not get the full immune response you would like. So if you can't give, if for some reason someone gave LAIV 2 weeks ago and the child, let's say it's a child, shows up in your clinic for either varicella or MMR, you need to wait a full 4 weeks before you give varicella or MMR. In this example I'm using to try to assure that there's no interference by the LAIV replication with a subsequent live vaccine.
Great, thanks. So there is a request. We have one question that requests a clarification for the egg changes. So to clarify, even people with an anaphylactic reaction or history of an anaphylactic reaction to eggs in the past can receive the flu vaccine this year?
That's correct. ACIP reviewed the data. One can read the data in the current ACIP recommendations because the vast majority of people who have anaphylactic reactions to egg have been demonstrated to safely receive influenza vaccines in a number of studies CDC and the ACIP reviewed within the past year. And this apparently has to do with the fact that the amount of egg protein or ovalbumin in influenza vaccines, at least in the activated vaccine, is very, very small. and for the vast majority of highly egg allergic people is not sufficient to induce a severe allergic reaction or anaphylaxis. So there is the cautionary statement that I read that if someone's had severe allergic reaction to egg in the past, they should receive the vaccine. Be sure you have giving them the vaccine in a place where they can be resuscitated, that is, receive epinephrine, manage an airway, and the other things you might need to do should they have a reaction to the vaccine. But all such persons are at present recommended to receive influenza vaccine, as are people who don't have egg allergy.
Great, thanks. One other question. Since the recommendation not to use LAIV this flu season has been called an interim recommendation, does that mean there's any chance that this will change during this flu season?
I'm not aware of any plans to reconsider the recommendation for LAIV non-use for 2016-17. My understanding is CDC and ACIP will review further data early next year and see if this recommendation should be altered for 2017-18, but I'm not aware of any plans to revisit the decision for this current season. So as far as I know, and we've been informed, LAIV should not be used for 2016-17, and that decision will not be changed for this season, though it will be revisited for the 2017-18 season.
Great, thanks. There's time for probably one more question. Are there any vaccines that cannot be given concomitantly with the influenza vaccine?
I'm not aware of any vaccines you could not give with an activated influenza vaccine. And I think the same is true for the LAIV vaccine, although again, we don't recommend you use it this year. But no, there's no recommendation. Now, there are some data that people should be aware of that in children who receive IIV and pneumococcal conjugate vaccine, and particularly if they receive DTaP, diphtheria, tetanus, acellular pertussis, their rate of fever and febrile seizures seems to be somewhat increased. Those three vaccines together, or flu and PCV13, have a higher rate of febrile seizures. So that's a consideration, but it is not a reason to not give those if they're otherwise indicated.
Great, thank you so much. That's all the time we have for questions today. So I will provide some continuing education credit information. For continuing education credits, please go to the webpage www.2a.cdc.gov/TCE online to obtain credit. Today's live CE event course number is WC2645-090716. To repeat, WC2645-090716. That's today's date and differentiates this presentation from others in the series. CE credit for the live course will expire on October 11th, 2016. You can search for the Enduring Archive course number, which is different, and that lasts until June 1st, 2018. That course number is WD2645-090716. You will also need the verification code, which is flu-824. And this verification code applies to both the live and the enduring program. I'll repeat the verification code, FLU-824. For help with the online system, available 8 a.m. to 4 p.m. Eastern Time, please dial 1-800-41-TRAIN. This corresponds to 1-800-418-7246. Or you can email ce@cdc.gov. If you have additional questions that you didn't ask on today's program, you may email us at nipinfo@cdc.gov. We'll try to respond to those as quickly as possible. Additionally, we will post answers to the questions we did not get to during this programming at www.cdc.gov/vaccines/pinkbook/pb14.asp. You can also call immunization questions at 1-800-CDC-INFO or 1-800-232-4636 from 8 a.m. to 8 p.m. Eastern Time, Monday through Friday. Additional resources you can use include the Pink Book, and the website for the Pink Book is www.cdc.gov/vaccines/pinkbook/index.html. It's available online, or you can purchase a hard copy at the link for the Public Health Foundation Learning Resource Center. Our CDC vaccine homepage is www.cdc.gov/vaccines/default.htm. Our resource guide for healthcare personnel entitled CDC Immunization Resources for You and Your Patients is listed at www.cdc.gov/vaccines/ED/imz-resources.pdf. That concludes our program. I want to thank Dr. Strickus for the presentation today, covering the topic in great detail and for answering your questions. Thank you very much and have a great day from Atlanta.